For this video, we'll begin looking at valvular heart disease. So when we take a look at blood flow through the heart, we have to remember that it has stop signs along the way. So when we are looking at valvular heart disease, we're going to be specifically looking at those stop signs. So just as a refresher, we know that we have the atrioventricular valves, which are your tricuspid and mitral valve. So they sit between the atria and the ventricle. We're going to call them AV valves. And then we have our semilunar valves, which are your pulmonic and your aortic. So we also have valves that are going to be looked at as to where they are locationally. If I'm looking at the right side of the heart, we're going to be looking at the tricuspid and the pulmonic. If we're looking at the left side of the heart, which for our purposes is going to be the most important, because if you do have valvular heart disease, the one that is most likely is going to be either mitral valve or aortic valve disease. So just like in everything else that we've talked about with cardiac, we have to remember our health promotion and disease prevention. We understand that this valvular heart disease can be congenital or acquired, and it's usually going to be acquired because we have we have untreated upper respiratory infections, usually bacterial. And what does that mean? It can be either untreated or undertreated, and it can be associated with any number of surgeries, oral disease, gingivitis, surgeries to the bladder. So anything that is going to promote some sort of bacteria growing in your body, and then it's going to be pumped around, and it's kind of find its own little home there on the structures of the valves. And as it goes, when it gets there, it's going to produce vegetation. So it's going to produce either scarring or these abnormal growths along the heart valves. And that's going to lead to ineffective pumping. So we're going to teach the client about preventing and treating bacterial infections. Again, because it's a valvular heart disease and it's more of a pump issue, we can talk about a low sodium diet and fluid restrictions. If they're having an acute episode, we're going to teach them about compliance with their underlying comorbidities, and as always, encourage them to exercise and to do things to improve the plaque in their body. So as we said, we're going to look at this from a left-sided and a right-sided kind of viewpoint or standpoint. For valvular heart disease, the effects of the heart over time as a pump are going to be reduced. And that's going to reduce the amount of filling time that you have in the left ventricle specifically, and that's going to decrease cardiac output. And that whole process is going to cause remodeling. And we have talked about remodeling already when we discussed heart failure, so we know that there are certain things that we can do to mitigate that remodeling from happening. In this illustration, we kind of see the locations of the pulmonic valve and the tricuspid valve, the aortic valve, and the mitral valve. Now remember, we are talking specifically about these. The tricuspid and the mitral valves are sitting between, and it's hard to see with the yellow here, but they're sitting between the atria and the ventricle. And then when we're looking at the pulmonic and the aortic valve, the pulmonic valve is going out to the lungs, and the aortic valve is going out to the body. Those are your semilunar valves, and those are semilunar based upon their shape. So if we suspect valvular heart disease, we have to do certain assessments. So a good way to remember this is all physicians take money, and we'll again revisit this concept. It's second intercostal space, right sternal border, second intercostal space, left sternal border. It depends on which book you look in. It's fourth or fifth intercostal space, left sternal border, and then it's going to be at the midclavicular line at the fifth intercostal space. So we'll just take our hand and go across, and we'll look at our aortic, our pulmonic. It's a little hard to follow. We try to highlight it as best I could. Our mitral valve and our tricuspid valve. You kind of see that they make this all physicians take money. So this little design across your body, across your thoracic cavity. What we could do, or what we should do, is we want to position the client leaning forward or in their left lateral recumbent position. And notice here that we are switching how we're using the stethoscope, right? It's a very soft sound, so we want to make sure that we're going to be listening to the bell if we're placing them in this left lateral recumbent position, just to be able to better hear these specific different heart sounds. When we look at valvular heart disease, it's either going to be classified as a stenosis, or you're going to have this insufficiency / regurgitation. So stenosis is a narrowing, it doesn't open properly, and a regurgitation or an insufficiency means it doesn't close properly. So those are going to cause specific signs and symptoms depending on which side they are. So this is why, again, it is so important for us to remember where blood flows from so that we can understand where blood is going to back up to. We've talked about the fact that it can be congenital or acquired. Congenital heart disease is exactly that. Newborns have structural changes to their anatomy. They have openings or closings or strictures that cause either a decrease in cardiac output or a mixing of deoxygenated blood with oxygenated blood. But from our standpoint, probably the most common one is going to be this acquired valvular heart disease, again, through untreated upper respiratory infections, history of rheumatic fevers. And let's be honest, we don't see a whole lot of rheumatic fevers anymore. Or just these client population that don't have access to good health care. We do associate a murmur with our valvular diseases, and a murmur is just a vibrating, a blowing, a whistling, or a rumbling noise. So you have changes to the structure of your heart valve, and that's going to cause turbulent blood flow, right? So it's like when you put your hand underneath the faucet, the blood before you put your hand, or the water before you put your hand there was flowing freely, it was making the same sound. And then when you put your hand in there and you're causing turbulence, you have all of these new sounds and the blood and the water splashing. So it's not uncommon for us to hear that, and that would be our first indication that a client does have valvular heart disease. If we hear something or they present with signs and symptoms and we suspect that they have valvular heart disease, the most common things that we're probably going to do is a chest x-ray, which is probably going to show us cardiomegaly, cardiomyopathies. We don't really see the valves on a chest x-ray, but we do see the signs and symptoms, specifically where that fluid is backing up to in the pulmonary congestion. You can see changes in your 12-lead ECG. When we talked about dysrhythmias, we kind of talked about how with chronic hypoxia, we could see changes in our T-wave. You can have T-wave inversion. We can see these changes that are going to be chronic in nature. So we need to be able to examine that and say, why do I now think that this client has some sort of hypoxia to the heart. And since we are looking inside the heart with valvular heart disease, we know that this would be because of a decrease in cardiac output. However, the biggest one that we're probably going to use is the same one that we're going to use for heart failure. Because now remember, a TTE and a TEE are going to be able to identify structural changes to the heart. That includes changes to our valves. Again, clients can be asymptomatic for years, and then we could just come in for any other kind of follow-up appointment, or again, just general feelings of malaise, fatigue, palpitations, whatever it may be, and then we diagnose them with valvular heart disease. Initially, again, it's kind of those generalized weakness, fatigue, palpitations. You may have some dyspnea that gradually progresses to orthopnea and paroxysmal nocturnal dyspnea. And then long term, you may end up with peripheral edema. Clients can have chest pain. Now remember, once blood leaves that aortic valve, the first place that it's going to go is to the coronary arteries. So if I have blood that is unable to participate in perfusion or participate in cardiac output, we're going to have less oxygen going to the coronary arteries. So it can present as chest pain, and or your compensatory mechanisms can activate, in which just case means you're going to have a high heart rate. You could have a dysrhythmia with a high heart rate. We talked about AFib with RVR. Generally speaking, aortic stenosis is probably pretty bad for us. When we were looking at valvular heart disease, I would say that that's the big picture one, because it's probably the most acute one that we could diagnose. Again, you could have lightheadedness or fainting. You could have peripheral edema. I do need to remind us now, if we have a client that has acute thready peripheral pulses, if they have widened or narrowed pulse pressures, if they have cool, clammy skin, that those are signs and symptoms of shock. And since we're having a stricture here, a stenosis, that's going to decrease cardiac output. That is the very definition of shock. So be careful. So right-sided signs and symptoms, left-sided signs and symptoms, you see that dyspnea and fatigue are for both. And that's just kind of the overall broad piece of it. And then those signs and symptoms are going to mimic left-sided and right-sided heart failure. So again, we said from our perspective, from a big basic nursing perspective, we are mostly going to talk about our clients with left-sided valvular disease, and that's why there is only going to be one slide over the right side. So if they do have a tricuspid valve stenosis or a pulmonic valve stenosis, our focus is going to be on prevention of the exacerbations of right-sided heart failure. So because I have a pulmonic stricture or a tricuspid valve stenosis, I don't have enough cardiac output on the right side of my heart going to my lungs, so it's going to try to beat harder to compensate for that. You want to monitor for acute pulmonary embolism. After all, this is if blood is sitting there, if it's not pumping correctly, it can pool and cause clots. Those clots are obviously going to become thromboembolisms. Or we want to make sure that they're not going to be at an exaggerated risk for recurrent endocarditis. So now I have this structural change there, and that bacteria likes to sit there. So if I have structural changes to the right side, the bacteria sits there, and the bacteria develops into an endocarditis. Medical management is appropriate for many older adults, with surgery being probably the big one, because we're going to let it go and go and go until they are symptomatic. And then we may have to do a balloon valvuloplasty or a commiserotomy or valvular replacement, which we'll talk about later. So the big ones that we're going to concern ourselves with are the mitral valve and the aortic valve. So we'll look at the stenosis first. We've already said that this leads to a decrease in cardiac output. You're going to present with hypotension, tachycardia, weak pulses. We know that those things are basically mean you're going into shock. And then you could have pulmonary hypertension as well. or cor pulmonale. So things to look for, we've already said that we expect a murmur, and then it's the left-sided signs and symptoms, right? So dyspnea, chest pain, fatigue, orthopnea, paroxysmal nocturnal dyspnea, narrowed pulse pressures. So we're going to do things to help this pump become more effective. Generally speaking, since we have talked about preload and afterload, one of the things we've talked about is the use of nitroglycerin, because you would think this is a constriction. So I want to open it up. I want to cause vasodilation. Unfortunately, because it's a valve, we want to keep in mind that nitroglycerin can cause some really bad things to happen, because nitro, remember when we said in our earlier videos that nitroglycerin decreases both preload and afterload. Well, if my whole problem is I don't have enough volume and I don't have a good enough pump, that's going to exponentially make the aortic stenosis signs and symptoms worse. So just be careful with the use of nitroglycerin. Here you kind of see the breakdown, because you do have very common signs and symptoms of left-sided heart failure. So I wanted to point out like the big ones, right? Chest pain. We know how important chest pain is. Chest pain, angina, crackles, narrowed pulse pressures, widened pulse pressures. In all of our cardiac lectures so far up to this point, we have talked about how bad those things are. So it's hard for people who write NCLEX, it's hard for your nursing faculty to sit there and go, oh my gosh, this list is so inclusive. How do I write a test question based upon this information? Because there's so much to choose from. You start with the big picture here. Your client presents with aortic stenosis. Which new assessment is most concerning to the nurse? And now the client has chest pain. Okay, so I care a lot about chest pain versus, oh, they have a little bit of a dyspnea on exertion, or they have a murmur, or they're having palpitations. So I've given you an example of 4 options to choose from, and I chose those 4 options from here, but chest pain is the priority. So try to make it make sense to the big picture stuff. So you have this like classic triad for aortic stenosis. And that's when, if you have aortic stenosis, you're the most sad. And it's syncope, angina, and dyspnea. With mitral valve stenosis, it's your A, B, C, D's, and E's. All right? Arrhythmia, aneurysm, bradycardia, low blood pressure, cardiac failure, cardiac tamponade, death, embolism. That's a lot. That's a laundry list. So I don't have to necessarily remember all of those, because I know that aortic stenosis, it's the big 3, and that's probably what NCLEX is going to test you over. Since it's a problem with decreased cardiac output, I want to make sure that we're giving supplemental oxygen. I want to make sure that we're assessing vital signs, that we're assessing pain, that we're using OPQRST. If it's an issue with too much volume, we can do fluid restrictions and sodium restrictions. We're going to make sure that they're on telemetry, because hypoxia can cause dysrhythmias. Again, we're going to just look back at our airway, breathing, circulation, changes in LOC, acute before chronic, least invasive to most invasive, Maslow's and ADPI. We're going to look back at our clinical judgment. If it's a volume issue, because fluid is going to back up, I have a stricture that's causing fluid not to be able to pump out. Fluid's going to back up. Well, that plasma portion of that is probably going to cause some edema, or it's going to cause pulmonary edema. So we would expect to use some sort of diuretic, hydrochlorothiazide, furosemide. If they are developing or they have a history of a dysrhythmia, we can use antidysrhythmic medications. And of course, because they're at increased risk for clots, especially if they have a valvular heart disease and a history of atrial fibrillation, we know how big clots are for those 2 things, we could expect some sort of anticoagulation therapy. We can do beta blockers, we can do ACE inhibitors, we can do ARBs, calcium channel blockers, and vasodilators. Anything that's going to decrease how hard your heart has to work to maintain cardiac output. Digoxin, yes, we can use digoxin. It's not used a whole lot. I would say probably the kiddos use it more now than the adults do because we know how bad it is for us. But I know it is still on NCLEX. So, and I know we've had this again in heart failure. Just make sure you remember for digoxin, you're going to count the pulse for 1 full minute. You're going to contact your healthcare provider because they're going to set some sort of parameters. Usually it's less than 60. Not really worried about greater than 100, but just be careful because you could be having some sort of tachyarrhythmia. Don't take it at the same time as antacids. Digoxin is highly protein bound, so it can bind to a lot of things. And then you want to be observant and you want to teach the client about signs and symptoms of toxicity. And, you know, I always get, it's the yellow halos. Nobody is going to ask you, no honest nursing professor is going to ask you about yellow halos because that's too easy. Because the earliest things that are going to be experienced by the client are going to be the fatigue, the muscle weakness, the nausea, the vomiting, the early signs and symptoms. If we're waiting till we get to yellow halos, then they're probably already digitoxic anyway. And again, remember, when we talked about digoxin, we said that you can get digitoxic with the first dose. It doesn't matter if it's the loading dose, it doesn't matter if it's an additional dose, whatever it may be, you can get digitoxicity very quickly, especially in the presence of hypokalemia. And then we've already seen that diuretics is one of the options that we have for treatments of valvular heart disease. So just try to think back to what you remember about digoxin. So that leads us to aortic valve insufficiencies, aortic valve regurgitation, severe dyspnea, chest pain, hypotension. This is a medical emergency. If somebody is telling you that they have this pulses of a water hammer, this really wide bounding pulses with hypotension, severe dyspnea, that we can't maintain their SpO2s on 100% non-rebreather, and they're complaining of chest pain 10 out of 10, it's a medical emergency. Not a whole lot I can do for the nurse. Contact the healthcare provider, get them scheduled out for a surgery or into the ICU for some more invasive monitoring. So things that we could expect long term is something like a balloon valvuloplasty. It's plastic surgery of your valves. It's an invasive, non-surgical procedure. Basically, we're going in and we're inflating a big old balloon. The balloon is inflated to enlarge that opening. We're going to institute precautions because it's still just like cardiac cath lab. We have that arterial puncture, and we're threading that guide wire and that catheter through the heart, especially if it's on the left side of the heart that we're trying to get to. It's got to go through the right side, into the left side. Of course, we want to monitor for systemic embolization. We want to monitor their cardiac rhythm, heart sounds, and cardiac output. If we don't believe that that's going to work, we're going to use mechanical valve. Mechanical valve used to be fairly common. I probably haven't heard a mechanical valve in quite a few years. Usually you would know that they had a mechanical valve because you'd be standing on the outside of the room and you would be listening to this click, 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 click. Now we've determined, evidence-based practice has determined, that we can go ahead and use bovine and porcine valve replacements because we really do try to wait as long as possible. And so generally the clients who are getting these valvular replacements are these geriatric clients anyway. So it's less about the fact that we have to go in and replace them and more about the quality of life. And that's a pig or a cow, bovine or porcine. So again, we have a client with valvular heart disease. We're going to stress the importance of prophylactic antibiotics, especially if they're having any invasive dental procedures or respiratory procedures. We want to teach them to do their daily weights. We know that the rules for heart failure, right? And these signs and symptoms do mimic heart failure. We want to make sure that we plan for them to have periods of rest, just like we would when we talked about heart failure. You know, you want to encourage exercise, but you're going to build yourself up to it. You're going to do the exercise, do the diet, avoid the caffeine, the alcohol, stop smoking, eat healthy. If you do have a fever, you should contact your healthcare provider. If you do end up with a petechial rash or shortness of breath, you want to report that to the healthcare provider. And then we're going to teach them about signs and symptoms of heart failure, because the signs and symptoms of valvular heart disease mimic heart failure, but they also cause heart failure, because your heart, because of that stenosis or that restriction or that inadequate cardiac output, has to work harder, and eventually it will fail. So that's what you need to know about valvular heart disease to be successful. So we've talked about left-sided and right-sided. We've determined that, you know, the left side of the heart is much more important than the right side of the heart. We're going to look at this mitral valve. We're going to look at this, and it's going to loop back over itself. So the aortic valve, that's actually going to go out here to this way, right? We can have issues with chest pain. We can have issues with signs and symptoms of left-sided heart failure, right? We're going to make sure that we're promoting rest, that we're auscultating heart sounds, that we expect a murmur, and then we're going to go back to look at those medications that we can use to improve cardiac output, but just be cautious of that nitroglycerin.